Welcome to Surgery Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. A link to the evaluation will be passed out and posted in the chat. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission. If you have a question for the presenter, please hold until the end of the talk. If you're attending virtually, you can enter your question into the Q&A feature. And now it is my pleasure to introduce our speaker for this morning. Dr. Eihab Abdelfatah is a board-certified surgical oncologist specializing in the care of patients with various types of cancer. He treats cancers of the digestive system, including the esophagus, stomach, pancreas, liver, small intestine, and colon, as well as skin cancers, soft tissue tumors, and cancers that have spread to the lining of the abdomen. He completed 2 advanced fellowships at Roswell Park Comprehensive Cancer Center, one in complex general surgical oncology and another in minimally invasive thoracic oncology, giving him specialized training in cancer surgery and less invasive techniques. Dr. Abdelfatah offers minimally invasive and robotic-assisted procedures that help patients heal faster and with less pain. He also performs cytoreductive surgery with HIPEC, a treatment that uses heated chemotherapy inside the abdomen during surgery to target cancer that is spread within the abdominal cavity. He is dedicated to creating personalized treatment plans and supporting patients through every step of their care. Now, before we begin, I know Dr. Foxhall would like to come up here and say a few words.
What a pleasure it is to introduce our new partner. As you can tell from his CV and what Suzanne said, he brings some more tools for us to treat our oncology patients in our group. And we are very grateful to have him here. I look forward to his talk about the management of gastroesophageal junction malignancies. And I'd like to welcome to the podium now my partner, Dr. Eihab Abdelfatah.
All right, thank you, Dr. Foxhall, for the kind introduction. So the topic that I'm going to be discussing today is cancer at a crossroads, evolution and management of GE junction adenocarcinoma. Now, when I say at a crossroads, this really has 2 meanings, which I'll try to illustrate. And one is the physical location at the crossroad of the chest and the abdominal cavity. But the other is also where we are in recent developments, which have really changed the management of these types of tumors over the past 3 years. I have no relevant disclosures. So I'd like to start with a case presentation. And this is not atypical of what you'll get in the clinic. So it's a 67-year-old man with a history of chronic GERD. He presents for progressive dysphagia. He had an EGD done by his gastroenterologist and demonstrated a partially obstructing mass, which began 38 centimeters from the incisors and extended down to 42 centimeters from the incisors. The Z-line was measured at around 39 centimeters, and they did an EUS staging the lesion as a T3N1 disease. He had a PET CT with no distant metastatic disease. So how would you treat this patient? What are the options for treating this patient? First of all, how would you classify this tumor? Is this an esophageal cancer or is this a gastric cancer? I will tell you that when you get these endoscopy reports, they'll often say esophageal cancer, and then you read it and it's actually a gastric cancer with a little bit of esophageal extension, or a gastric cancer and it's mostly in the esophagus but a little bit in the stomach. People, especially endoscopists in the community, are rarely going to be so precise in their description, and they will often, again, depending on who's doing your endoscopy, may give very incomplete information. That endoscopy report defined the extent of the tumor, where it starts, where it ends, where the Z-line was. Very often you won't get that. It'll just be a description of a tumor in the distal esophagus causing partial obstruction. They don't really give any measurements. You have no idea where it's located. You have no idea how close it is to the GE junction. And now it's your job to figure all this out. So would our perioperative therapy change based on this classification? Does that matter? If you look at the literature for GE junction tumors, you're not going to find a lot on GE junction tumors specifically. What you will find is gastric cancer literature, which will include GE junction tumors with it, or esophageal cancer, which will include GE junction tumors with it. So it's kind of this stepchild between the two, where sometimes they're included in trials and literature for gastric cancer, sometimes it's included in trials and literature for GE junction cancer. But rarely are they evaluated as kind of a distinct entity of themselves, and should they be? And then what type of surgery should this patient undergo? A lot of that is going to depend on who they get referred to. So as you guys know here, they'll be referred to one of the surgical oncologists or hepatobiliary surgeons, and whether they need a gastrectomy or an esophagectomy, will make that decision. But in a lot of places, these type of patients get referred to a thoracic surgeon. And obviously, if you're a thoracic surgeon, they're much less likely to perform a total gastrectomy than an esophagectomy. Or they get referred to a general surgeon, and they're much less likely to perform an esophagectomy than they are a gastrectomy. So how much of this decision-making is based on valid biologic or anatomic considerations, and how much of it is based on who they're getting referred to, what the referral pattern is, and what the comfort level of the person getting that referral is in those procedures. So this is just a quick slide reminding us about the anatomy. The esophagus typically starts at around below the cricopharyngeus, so around 16 centimeters from the incisors when you measure endoscopically, and that could vary a little less or a little more depending on height and other patient factors, the patient's anatomy. But this part is generally considered the upper esophagus. The mid-esophagus is when you get around the carina, and then when you get down to around 32 to 38 centimeters or so, that's when you get into the distal esophagus and then into the GE junction. And the GE junction is probably somewhere around 33 centimeters to around 45 centimeters, and that's kind of going to be your GE junction. And that's where the majority of tumors end up being, whether they get classified or esophageal or gastric, they end up being in this area. And this is important, and this is a map of the nodal drainage, but we'll see how the nodal drainage patterns play a role in the decision-making, and both surgically and in the perioperative therapy. So this is a Seward classification. You guys are all familiar with this, or should be familiar with this. And this is a great way of classifying the GE junction. It's purely anatomic. It's purely based on anatomic landmarks and measurements, and it's a great tool for telling us, where is the lesion? What are we talking about? How high or low is it in the esophagus? And this is a good way of reporting, which even this way many endoscopists will not do. However, and what I would say is, these tumors are more esophageal in origin. These are kind of the true GE junction tumors, but you'll often get tumors that extend, farther along. It could be a long segment of tumor, but where it is where the epicenter of the tumor is. So that's a great anatomic description, but we know that when it comes to cancer, biology is king, right? So, and this comes from a saying where essentially that biology is king. As surgeons, we can do what we can do, but ultimately disease biology is what dictates prognosis and long-term survival. And so let's look to see, is there anything biologically that's happening in this area to kind of clarify or distinguish GE junction tumors? And the first place to look is molecular. right? So this is from the TCGA. So the TCGA is the Cancer Genome Atlas. This was a huge project by the NIH where they collected a lot of different primary cancer samples from around the country and from numerous institutions, and they classified the molecular profile of those cancers. And so this is for the esophageal cancers that were collected. And they did molecular testing for genetic mutations, the frequency of genetic mutations, and other important factors like microsatellite instability and immune markers. And what they found, and what we see here from the TCGA analysis, is that there's a continuum, okay? As we know, upper esophageal and mid-esophageal are much more likely to be squamous cell carcinomas. And molecularly, they are very different from when you start to get down into the mid-esophagus and then the lower esophagus and GE junction, where you now change to this chromosomal instability molecular profile of adenocarcinomas, okay? So almost exclusively, the distal esophageal and GE junction cancers are going to fall into this chromosomal instability subtype with p53 mutation, VEGF amplification, and ERB2 amplification. Now, this is important because what this tells us is the squamous cell carcinoma of the esophagus is essentially a different disease from an adenocarcinoma of the distal esophagus and has more in common molecularly with head and neck oropharyngeal cancers that are squamous cell carcinomas than it does with the distal esophagus. Similarly, as you come down into the stomach, you see that the GE junction tumors have you have a much higher rate of this chromosomal instability at the proximal stomach, and then as you get farther down, you get more of the microsatellite unstable, the diffuse type kind of classic distal gastric cancers that are associated with H. pylori. You see those in the distal stomach, and they have a completely different molecular profile than the chromosomal instability ones in the proximal stomach and the GE junction, okay? So what does that tell us? If you have a GE junction tumor, it has more in common with a distal esophageal tumor or a proximal gastric tumor than a proximal gastric tumor has in common with a distal gastric tumor, or that a distal gastric tumor has in common with an upper esophageal squamous cell carcinoma. These are different diseases. There's a disease continuum, or there's a continuum of the molecular characteristics of these cancers as you progress down the GI tract. And that makes sense intuitively because the factors that cause a distal esophageal or a GE junction or a proximal gastric cancer are different from the factors that are going to cause a distal gastric cancer or an upper esophageal cancer. So that starts to kind of classify it for us from a molecular biology standpoint. And the NCCN groups esophageal gastric junction cancers with the esophageal cancers when they give their recommendations. But I don't think that tells the whole story, and I think there's more to it than that. So while this gives us some idea, I think we need to look into this further. So historically, how have esophageal and gastric and with those GE junction cancers been treated? Well, in the early to mid 20th century, like with all other cancers, the treatment was upfront radical surgery with Halsted principles. So the Halsted principles were to get wide margins, radical lymphadenectomies, taking a lot more than we now know a lot more than you actually need to take, with the thought that if you clear more of the tissue around it, you're going to have better survival. Unfortunately, this is not how things worked out. And in the 1980s and 1990s, there was attempts to start adding additional adjuvant therapies because survival rates were just very poor. So pre-op and post-op radiation therapy attempts in the 80s and 90s were initially unsuccessful at improving outcomes, and they also tried different chemo regimens. At the time, pretty much what they had was 5-FU and platinum-based agents, and they had mixed results with this. And so the 5-year survival rates during this time was around 10 to 30%, even with resection. So pretty poor. Then in 2012, these results were published from the Cross trial, okay? And this is a seminal trial. This is one that you guys should know about. And essentially what they did was neoadjuvant chemoradiation with carboplatin and paclitaxel, along with concurrent radiation to 41 gray. This was done prior to surgery, then 4 to 6 weeks after completion of therapy, patients would undergo resection. What they found was, first of all, that survival rates were significantly better in the chemoradiation group. The RZO resection rates were much higher in the chemoradiation versus the surgery alone group. And the path complete response rate, meaning they resected the tumor, there was no residual disease left in the tumor under pathology, microscopically, was 29% overall. 23% of this was for adenocarcinoma and 49% of this was squamous cell carcinoma. So this looks great, right? These results, this solves it. We should give everybody chemoradiation. And this did change the standard of care. However, there's a couple problems with this trial, okay? Number one is, while the patients were mostly adenocarcinomas, there was a significant portion of squamous cell carcinomas. And if you remember what I said about squamous cell carcinomas molecularly being closer to head and neck cancers, if you know anything about head and neck squamous cell cancers, you know that they're very radiosensitive. They respond very well to chemoradiation. And often they're even treated with definitive chemoradiation because some of those procedures can be highly morbid. So as expected, if you think of esophageal squamous cell cancer as just a distal extension of the head and neck squamous cell cancer pathology, they responded very well to chemoradiation. So if you look at the survival curves that are split up between adeno and squamous cell carcinoma, so this bottom line is squamous cell carcinoma surgery alone. This top line is squamous cell carcinoma that underwent neoadjuvant cross-trial regimen, okay? Look at the huge difference. So what's really driving the improvement in survival is the squamous cell carcinoma group. The adenocarcinoma group, while there was some improvement, was not nearly as robust, okay? And we'll talk about why that is in a few minutes. And one thing to note of these, they classified 24% of the patients in this population as GE junction tumors. So again, they're never in a trial by themselves. It's always in a trial either with esophageal cancer or a trial with gastric cancer. So when we're extrapolating the data, we're extrapolating from both gastric and esophageal cancer trials. So in 2000, while the cross trial was going on, they were doing trials in gastric cancer as well. The first one was the Gip McDonald trial, which used adjuvant chemoradiation for resected gastric cancers, 25% of which was in the cardia and GE junction. And these were all adenocarcinomas, which is important. You see that there's an improvement in survival with chemoradiation, okay? Now, this is the first study which really changed the management that there should be additional therapy given for gastric cancer, in this case, adjuvant chemoradiation. And then that would later change, as we'll see. But one thing I want to point out here, lymphadenectomy rates in this group. You had 10% D2, which is really what we aim for when we do a gastrectomy today. But at the minimum, you want a D1, which is taking the lymph nodes immediately around the stomach. Only 36%. More than half of the patients in this trial had a D0 lymphadenectomy rate, meaning they essentially had almost no lymph nodes removed during their gastrectomy. And we'll talk about this a little bit, about how surgical technique has also influenced the outcomes and the changes in the perioperative therapy. But I think it's important to note that for these patients, when they would talk about local and regional recurrences, the surgical technique that was being done was not what we're doing today, especially with lymphadenectomy. And that could explain some of the increased regional recurrences. But in addition, they were also getting significant numbers of distant metastatic disease. Now, along with the McDonald trial, at the same time, they were also doing the MAGIC trial, which instead of adjuvant chemoradiation used a perioperative regimen of epirubicin, cisplatin, and 5-FU, so pre and post-op chemotherapy. 25% of these patients had lower esophageal and GE junction tumors. and we saw an improvement in survival with perioperative chemotherapy. So after this trial was published, the standard of care became, if you had a locally advanced gastric cancer, they received perioperative chemotherapy with the MAGIC trial regimen, and that was the new standard of care. And that was true until FLOT came out, and this was now a 3-drug regimen, really 4 drugs, but leucovorin doesn't count. It's just a sensitizer for 5-FU. But essentially, they compared this regimen to the MAGIC trial regimen and saw an improved survival over that. So the standard of care treatment for gastric cancer became FLOT. 56% of the tumors in this study were GE junction tumors. So again, you have GE junction tumors in the CROSS trial, you have GE junction tumors in the FLOT trial. So where does that leave us? Well, we now have a situation where you have 2 standard of care regimens. You have the CROSS trial regimen, which is neoadjuvant chemoradiation. You have the FLOT trial regimen, which is perioperative chemotherapy, no radiation at all. Which one do you choose, right? Well, if you're a thoracic surgeon who gets the referral, and you decide that this person is going to get an esophagectomy, you're probably going to do CROSS. If you're a surgical oncologist or general surgeon who gets the referral and you decide, I'm going to do a total gastrectomy for this patient, you're probably going to do FLOT. Is there any biological rationale to that? Is that decision being made based on good, sound data, or are we just kind of, picking and choosing? The NCCN guidelines at this point really didn't help either. They said you could do either one, and that was the kind of, it was a dealer's choice. So why choose one over the other? Is there any biologic rationale for one over the other? Well, the first thing I want to point out, and this is, I think, a point that many residents don't get, but chemoradiation, like in the CROSS trial, is not systemic therapy, okay? When you talk about chemoradiation, the chemotherapy is a sensitizer for the radiation that's being given. The dosage and duration of the chemotherapy agents that are given in chemoradiation, like in CROSS, are not the same dosage and duration that you're given, for example, in FOLFOX or in FLOT or in other systemic therapy regimens. So the purpose of the chemotherapy drugs in those is not to treat systemic disease, it's to sensitize, to make the tumor more radiosensitive when you treat it with the radiation. That's why it's a shorter duration, and that's why they don't get nearly as much chemo. So when you think of chemoradiation, I don't even think of it as systemic therapy. It's essentially local therapy, okay? So when you're giving chemoradiation followed by surgery, what are you doing? You're giving a local therapy, CROSS, followed by another local therapy, surgery. At no point did you give them any systemic therapy. That may be okay for squamous cells who have high rates of local recurrence, but as we got better with our surgical technique and lymphadenectomy for esophagectomies and gastrectomies, the local recurrence rates became less of an issue for adenocarcinomas because adenocarcinomas are much more likely to recur in a distant metastatic disease, okay, liver, lungs, peritoneum. The next thing to consider is that, and this, I kind of mentioned this, local and regional recurrence rates are higher in squamous cells and before the improvements in surgical lymphadenectomy technique. But when we improved that, those local recurrence rates dropped, but the distant metastatic disease still continued. So then how do you treat that distant metastatic disease? Well, you need systemic therapy, like in FLOT. And so that's this essentially says what I described. So then, in between, so eventually you have to think. They got to do a trial that compares CROSS to FLOT because that's the only way to figure out what we should be doing. Well, in between doing that, they did this study where they finally added something of systemic therapy to the CROSS trial regimen, where they added nivolumab adjuvantly. So anybody who had a CROSS regimen, got resected, did not have a path complete response, they would get nivolumab, and those patients did better. And it would make sense because that's the first type of systemic therapy those patients are getting. Now, finally, in 2025, and this is what I'm talking about in terms of the recency of all of this, the trials that I'm going to be talking about moving forward, most of them have been published in the past year. The NCCN guidelines for this have been updated in the past year. So this is actually actively changing during your training. So this is the ESOPEC trial was a German phase 3 multi-center trial. It included 35% Seward 2 and Seward 3 GE junction cancers. There was also Seward 1 cancers, but they grouped those with esophageal. And what they found was that there was better overall survival and progression-free survival with FLOT compared to CROSS. These are the two lines. This one is CROSS, this one is FLOT. They also saw higher rates of distant metastatic recurrence with CROSS, okay? And that's, again, not surprising, right? You're giving, those patients essentially are not getting systemic therapy. I don't think the patients who got the CROSS regimen did not get adjuvant nivolumab because this study was going on before that study came out. And then you actually even saw higher rates of path complete response with FLOT, which was interesting because you would think with the chemoradiation you may see higher rates of the path complete response on resection because they're getting radiation, but you actually didn't. You saw higher rates with FLOT. So if you look at the NCCN guidelines now, the preferred regimen has shifted to FLOT for both esophageal and gastric cancers. You can still give chemoradiation in select circumstances, or if you think they're not going to be surgical candidates, but it's now FLOT. And then this is the most recent study, the Matterhorn trial, which also added darvalimab to FLOT and saw even a greater improvement in overall survival a greater improvement in progression-free survival, but the overall survival was not significantly different, but they had not yet had enough follow-up. So we'll see what the long-term results of this are if we get the addition of immune therapy, okay? So let's shift gears a bit because, as surgical oncologists, we like to kind of dictate the care of our patients, but at the end of the day, we're not medical oncologists, we're surgeons. And so how do we treat these patients surgically? Well, for Seward 1, these essentially are so high up in the esophagus that you're essentially going to treat them similar to esophageal cancers and they're going to require esophagectomies. But Seward 2 and Seward 3 gastric cancers, GE junction cancers, are where there's going to be some variability, okay? If you have a true Seward 2 GE junction cancer, they can potentially get an esophagectomy or a gastrectomy, okay? So how do you decide? Is it, again, based on whether you're a thoracic surgeon or a general surgeon and whether you're more comfortable doing an esophagectomy or a gastrectomy? In a lot of cases, yes, that is why the decision is made, but is that the right way to make the decision, or should that be the way to make the decision? So one consideration is anatomic. So you can go up pretty high, especially if you're doing things robotically, pretty high up into the mediastinum and transect the esophagus, pretty high up. But the problem is you have to reconstruct it. You have to put things back together. And the higher up you go in the esophagus, the harder it is to get that loop of jejunum that you're bringing up for the mesentery to allow it to reach up to make an anastomosis. So there is a technical limit to how high you can go up with a gastrectomy where doing an anastomosis no longer becomes feasible. So we'll talk about that and how high is too high for a gastrectomy. And then even if you were technically, the most gifted surgeon and you could do anastomoses through the hiatus and be able to make it work, biologically does it make sense? Is there a limit to how high you should be going for a gastrectomy where you should be transitioning to an esophagectomy? And what dictates that limit? So this is a graph taken from a really nice study out of Japan, and you'll find that a lot of these studies that I'm going to be talking about come out of Japan, China, and Korea because they just have much higher rates of gastric cancer and much greater experience than we do in the West. But they essentially took resected gastric cancer patients and mapped out what are the nodes what were the positive nodes for those GE junction cancer patients and what the frequency of the different nodal stations was in terms of their being positive. So the lower mediastinal nodes, 110, 111, 112, and hold on, I have a picture of where that is. So 110, 111, 112. These are essentially like the distal paraesophageal lymph nodes up here, which you would not get from the abdomen. Those nodes, whether those nodes are positive or not has a direct correlation to how much length of esophageal involvement there is with the tumor, okay? So if you have less than a centimeter of esophageal involvement of your tumor, you have pretty low rates, like less than 1% that those nodes are positive. Even 1 to 2 centimeters, the rates are still below 10%. Once you start getting 2 centimeters, 3 centimeters, 4 centimeters, those rates of nodal positivity really go up significantly, okay? So 2 centimeters seems to be the inflection point for where there's an increase in those distal paraesophageal nodes becoming positive, and those should be removed as part of your lymphadenectomy. So if you want a biologic rationale for where to kind of put your limit as at where you should do a gastrectomy and where you should transition to esophagectomy, around 2 centimeter of esophageal involvement is where that cutoff should be, okay? And if you look at that even from a technical standpoint, once you start getting above 2 centimeters, it starts to get pretty hard to then do an anastomosis as well. Because now you're getting actually higher up into the mediastinum and you're gonna have issues with your jejunum reaching due to tension on the mesentery. So 2 centimeters, I think, is a good cutoff point. Now, the surgical options here are esophagectomy, and you could choose to do your esophagectomy, Ivor Lewis, transhiatal, McEwen. I'm not going to go into the details of, which to choose. I think that's partially patient factor, but partially also your training and what you're comfortable with, or a total gastrectomy. And those are your 2 options for how to treat them, right? Or is there a third option? Is there something else that we can do? So, proximal gastrectomy. Now, everybody's heard of a distal gastrectomy or a subtotal gastrectomy, but a lot of people have not done or heard of a proximal gastrectomy. We do partial gastrectomies even in cancers for distal gastric tumors, and that's considered oncologically acceptable, right? So is this oncologically acceptable for a proximal gastric tumor? Can you do the same? And can you maintain the oncologic principles of negative margins and appropriate lymphadenectomy when you're performing a proximal gastrectomy, okay? Now, this is back to that paper that I was talking about that mapped the lymph nodes and how their rates of positivity. If you look at, where most of the lymph nodes are positive for GE junction tumors, they're gonna be where you would expect, around the distal esophagus, proximal stomach, along the lesser curvature of the stomach, the left gastric artery nodes. This is the proximal hepatic artery, 7%, relatively low, and the proximal splenic artery. But then look down here at the right gastric and right gastroepiploic, 1% and 1.7%, really negligible rates of positivity for these lymph node stations. So if you did a proximal gastrectomy where you removed the proximal portion of the stomach, did your lymphadenectomy clearing out the celiac trunk and its branches, but left the gastric and gastroepiploic, are you really sacrificing anything oncologically with only 1% lymph node positivity rates of those lymph node stations? There's been multiple Chinese, Korean, and Japanese retrospective series which evaluated proximal gastrectomies, and they found no difference in overall recurrence-free survival compared to total gastrectomy in T1 or T2N0 proximal gastric GE junction cancers. So those studies mostly limited their study population to early-stage gastric cancers. However, there was an Italian multi-center retrospective study comparing proximal to total gastrectomy, and this one included T3 and node-positive disease, so not only early-stage cancers. And they also found no difference in survival outcomes between the 2 groups. And these are the 2 groups. The green is the proximal gastrectomy and the blue is the total gastrectomy. So what that tells us is from an oncologic standpoint, you can maintain oncologic principles by removing the proximal portion of the stomach as opposed to doing a total gastrectomy. But functionally, and actually in the Japanese cancer treatment guidelines, which are good general guidelines for performing gastrectomies, proximal gastrectomy is a valid option, but however, they limit it to cases of T1N0, so they still limit it to early stage gastric cancers. Now, let's say you do a proximal gastrectomy. So you're convinced about the oncologic rationale for it. How are you going to reconstruct this? So this is kind of the most straightforward way, right? You would cut the proximal stomach, you'd bring up the stomach, anastomose it to the esophagus. So what can be the problems by doing this? Well, first of all, you've removed the lower esophageal sphincter completely. You still have an intact pylorus, and you've denervated the remaining stomach because when you cut the esophagus and the stomach, you cut the vagus nerves along with it. So you're going to have horrible GERD, you're going to have severe reflux gastritis, and patients will have a poor quality of life because of this. And for this reason, proximal gastrectomies really, although oncologically and technically feasible, really were not seen as a valid option because the functional outcomes were so poor that you just didn't want to do this to someone. And it would be better to just remove their entire stomach and do a Roux-en-Y esophagogynostomy. There's been modifications attempted for this. People have described like double flap techniques, doing a fundoplication around the anastomosis, ways to kind of create almost a pseudo sphincter of the lower esophagus, but they have never really caught on. So it was largely abandoned until people started to try different reconstruction techniques. And the two most common ones you'll see are jejunal interposition and by far the most common double-tract reconstruction. And I'm going to focus the rest of the talk on this reconstruction because this is the one you'll see the most often in the literature, and this is the one that I've done when I've done proximal gastrectomies. This is what it looks like, okay? So essentially what you do is you do your proximal gastrectomy, and very similar to a total gastrectomy, you're essentially doing a Roux-en-Y esophagogeg, and these are kind of general measurements that you would use when you're doing this. And then you leave the distal about 40% of the stomach, and you make your anastomosis here, you make your JJ anastomosis, but you make a third anastomosis to this distal gastric pouch, okay? So now food can come down here, and it can go here, and it can also go here. So let's see how the outcomes of this have been. First of all, you're going to get near complete elimination of your reflux esophagitis, okay? Just like a total gastrectomy. Part of the reason with the total gastrectomy, because you have the Roux-en-Y anatomy, you're going to get much less reflux, because, unless you make your roux limb way too short, but around 30 centimeters or so, 30 to 40 centimeters is the length that most people make it. Remember, this is different from a gastric bypass. You don't want to make it too long because after a gastrectomy, especially a total gastrectomy, people are going to lose significant amounts of weight that you don't want them to lose weight, unlike a gastric bypass. Now, retrospective series and meta-analyses suggest that proximal gastrectomy with double-tract reconstruction results in better body weight preservation, lower rates of anemia, less need for vitamin B12 supplementation, and preservation of skeletal muscle. So if you guys have ever seen a total gastrectomy patient, what they look like before and after surgery, I tell patients that after this operation, you will lose about 20 to 25% of your body weight. So if you weigh 200 pounds, you're going to lose 40 to 50 pounds. It's a lot of weight. There's no way to avoid it. You no longer have the gastric reservoir, and you could do like a J pouch. You could do there's different reservoirs that people try to do, but they really don't change outcomes very much. People are going to lose very significant amounts of weight. And so the goal with this is to see, can we improve people's ability to eat? Can we improve people's ability to maintain their weight and improve their quality of life? Because a lot of these patients, especially if they've been having dysphagia and obstruction, they may have issues beforehand which have led them to lose weight to begin with. So now they're already starting with some weight loss, and the surgery is going to even give them more weight loss. nutritional supplementation is very important with these patients, and that's why almost always I will place a J-tube at the time of these operations as well. Now, there was a randomized controlled trial in Korea which compared proximal gastrectomy with double-tract reconstruction to total gastrectomy for early stage proximal gastric and GE junction cancers. This was called the Class 5 trial. What they found was that there was no difference in periop morbidity, mortality, or reflux esophagitis. The surgery didn't take significantly longer because you're doing that one additional anastomosis. But they did find a significantly higher number of retrieved lymph nodes and positive lymph nodes in the total gastrectomy group compared to the proximal gastrectomy group. However, and this is where it comes to the surgical technique, I purposely avoided talking about the whole controversy between D1, D2 lymphadenectomy. So if you're not aware, D1 lymphadenectomy is the lymphadenectomy of taking all of the perigastric lymph nodes, whereas D2 includes the lymph nodes along the celiac artery branches, namely the hepatic artery, the celiac trunk, and the splenic artery. Eastern studies have shown improvements in survival with D2 lymphadenectomies. Western trials have never shown significant improvements in survival, but it's still recommended to do a D2 lymphadenectomy, or what most people will do is kind of a limited D2 lymphadenectomy. Now, if you look at this study, if you look at the studies that are lymph node retrieval rates now compared to the early studies we were talking about, like the McDonald trial, where they did, more than half of patients had a D0 lymphadenectomy, there is a big difference in the number of lymph nodes retrieved, okay? Even if you did so for these patients, even the ones who had a double-tract proximal gastrectomy, you're talking about a difference of 40 versus 50 lymph nodes. Whereas in those earlier studies, they would retrieve like 5 lymph nodes, okay? Part of that has to do with surgical technique. Part of that has to do with pathologists being better at identifying lymph nodes. But the point is, there's probably an inflection point with the lymph nodes where getting more lymph nodes no longer does anything in contributing to survival. It becomes more a marker of prognosis and better staging of the disease. But even then, 40 versus 50 lymph nodes, I think by the time you've gotten to 40 lymph nodes, you've adequately staged that disease. So when it comes to lymph nodes, and especially with the addition of perioperative therapy, because again, it's whether you consider lymph nodes to be truly tumor or markers of more advanced or systemic disease, there's probably an upper limit where getting more doesn't really do anything for you. And I think we've reached that upper limit, especially in this. So that's why, although there was differences in lymph node positivity and retrieval rates, there's no difference in recurrence-free or overall survival, because there's probably a certain point where getting more lymph nodes doesn't do anything. Now, what did they find in terms of the long-term outcomes that they were really looking at, which was the hemoglobin and vitamin B12 supplementation and quality of life. So they saw that there was decreased level of hemoglobin drop long-term and decreased rates of anemia, which makes sense because you're maintaining your gastric antrum, so you're maintaining intrinsic factor, okay? Decreased need for vitamin B12 supplementation, and increased quality of life survey metrics, which they had a survey asking these patients. In terms of weight loss, I don't think they saw a significant difference in the weight loss with long-term outcomes. However, as I mentioned, other studies have shown improvements in weight loss. And so now we have a currently ongoing trial, the Trans-Pacific Multi-Center Collaborative Study of Minimally Invasive Proximal versus Total Gastrectomy. Usually these studies have like a nice acronym, but for some reason this one they do not. And this is a study between Eastern and Western institutions. So some of these people, if you'll recognize, there's people from MD Anderson, Sloan Kettering, Mayo Clinic, and then multiple Japanese and Korean centers. And essentially what this is it's a multi-center prospective cohort study that's going to compare minimally invasive proximal to total gastrectomy for proximal gastric and GE junction cancers. They're measuring oncologic and functional and quality of life outcomes, and the patients are not limited to only early stage disease. They're including node-positive disease, locally advanced tumors, and patients that are receiving neoadjuvant therapy. So what is the take home from this, especially for these sewer 2 and 3 GE junction cancers? So this is from a review article we wrote 2 years ago on GE junction tumors, and this is kind of what I use as my guideline. If you have less than 2 centimeter esophageal involvement, you can do a total or a proximal gastrectomy. More than 2 centimeter esophageal involvement, you should probably do an esophagectomy. And you can determine that degree of esophageal involvement pre-op with, usually I'll do like mapping biopsies, 1 centimeter, 2 centimeter, 3 centimeter above the GE junction, so I know beforehand, this is the operation I'm doing. I'm not going in there and kind of trying to decide at the time, am I doing an esophagectomy or am I doing a gastrectomy? If you have, right now as it stands, if you're concerned about advanced stage disease or there's diffuse gastric involvement where you're worried about a positive margin, you should probably aim for total gastrectomy. If it's early stage, and definitely if it's localized disease like T1 or T2 or node negative disease, it's not diffuse histology, then you can consider a proximal gastrectomy with double-tract reconstruction. And even in advanced stage disease, this may be appropriate, especially after perioperative therapy. However, I will say that this is still an active area of investigation. So if we look at future directions here, we need to see what the long-term results of FLOT-DARVA will be from the Matterhorn trial. Will the incorporation of immune therapy to the FLOT regimen, show long-term overall survival benefits? We need to see what the proximal gastrectomy international trial results are. And, and there's ongoing trials now looking at organ preservation for esophageal and GE junction cancer. So similar to rectal adenocarcinoma, where we now have a watchful waiting approach for clinical complete response, people have started to look at this for esophageal adenocarcinoma. For squamous cell, it's something that's already been practiced now for some time because of the very high complete response rates for squamous cell. But for adeno, this is not something that we've done historically. There's recently a trial that was published in April of this year called the SANO trial, where they randomized people with esophageal or GE junction cancers who underwent a cross regimen. So this is the first, issue obviously with this study, because as they were performing this trial, ESOPEC had not come out yet. So all these patients were still getting cross. So these patients all got a cross regimen and then were assessed for clinical complete response. And they did this with endoscopy, with EUS, and PET-CT. And if they determined that the patient had a clinical complete response, they would randomize them to either active surveillance arm or upfront surgery arm. And what they saw was that between these two groups, overall survival was not any different. However, let's look at what happened to the patients who went in the active surveillance arm. Because if you went in active surveillance and you developed local disease, you would then get surgery. Of those patients who had, so first of all, the clinical complete response rate was actually pretty good. It was 35% of all patients, okay? That doesn't mean pathologic complete response. That means clinical complete response. And I think that's borne out in what happens to those patients following. So from the patients that underwent the active surveillance, 17% of those developed distant Mets at some point during surveillance. That probably would have been unavoidable with or without surgery. However, 48% developed isolated local regional recurrence, and they ended up undergoing surgery. So nearly half of the patients actually did end up requiring surgery because they developed a local recurrence. So you could look at this as one of two ways. You could say that, well, this isn't really ready for prime time yet. We still need better neoadjuvant therapy because almost half the patients ended up needing surgery. Or you could look at this and say, well, half the patients didn't get a local recurrence and didn't need surgery, so you saved half the patients from getting surgery. It depends on how you look at it. I think it's still not something that I would recommend or do for my patients unless they were a very poor surgical candidate and I was trying to avoid operating on them. But, it's an interesting study. And it's definitely, I think, something that will be looked at in a future direction, especially as the perioperative therapy is changing from cross to FLOT and FLOT-DARVA, which anecdotally may be having some higher pathologic complete response rates. All right. I'm happy to take any questions, and thank you for giving me the opportunity.
Thank you so much. Excellent. If anybody has a question or a comment, please raise your hand and I'll bring the microphone to you.
That is one of the best talks and overviews I've ever heard. And it's so up to date that is, at the meetings we go to, we don't hear things that are this up to date and what the current trends are. It seems like biology's king. I think all of us know that. Where do you think we're going to go? It seems like across the board in oncology that we're doing less and less surgery. Is there a potential there for this?
Yeah, I think the last study that I showed with the Sano trial is the inklings of that thought process starting. I think always, the whole idea of biology is king is to say that cancer, especially adenocarcinoma, these tend to be more systemic diseases, and our survival has only improved not necessarily with better surgery, but with better systemic therapies, and that's what we're seeing here. And so once you can control, and we've seen it in breast, we've seen it with melanoma, the better systemic therapy you get, the more you're able to avoid sometimes surgery. But on the flip side, the better systemic therapy you get, sometimes even in more advanced cases, it may make things that you would never have considered operating on now potentially operable because you're able to control the systemic disease. I mean, you look at colorectal cancer, right? The amount of time that we spend, the time and energy and procedures now that are done on patients with metastatic disease that years ago would never have been even considered for local therapy is only made possible because of the improvements in systemic therapy. So I think the two things go hand in hand. I don't think surgery is going to go away, but over time, certain patients will no longer maybe require surgery, and other patients who would never have been considered could be potentially considered for a curative intent.